Good morning. So my name is Mohamed Zagzoog. I'm going to present the second asymptomatic carotid surgery trial, a randomized comparison of carotid artery stenting versus carotid endarterectomy, which was published recently in the Lancet journal, a well-reviewed journal. So it was published by a group of scientists and researchers in Oxford last August. So as a brief introduction to the trial, so as we know, the severely stenosis carotid arteries can lead to stroke with either carotid artery stenting or carotid endarterectomy can restore patency to the arteries and can reduce the long-term morbidity and mortality. In North America, about 100,000 surgical carotid stenting have been done yearly to treat the carotid artery stenosis. However, some procedural risks have been decreased over time, but there is still a 1% risk of disabling stroke or death. And there is also about less than 1% or 2% of non-disabling stroke, particularly with carotid stenting, and the MI or the cerebral nerve palsy with carotid endarterectomy. However, there is often uncertainty about whether we either choose carotid stenting or carotid endarterectomy for the patients. So what's the method and the study design for this trial? So it's an international multi-center randomized trial, have been done among 33 countries, and that's included 130 hospitals have been collaborated for this trial. So it was among patients who have been asymptomatic with carotid artery stenosis, and they have been suitable for the carotid stenting or have been suitable for carotid endarterectomy. As for the inclusion criteria, so any patients with a severe unilateral or bilateral carotid stenosis, generally on the ultrasound, they had a stenosis more than 60%. They have been included in the study. However, they have to be asymptomatic for the last 6 months. That does not cause any symptoms for the last 6 months. And there has been a CT or MRI confirmation for the suitability for the carotid stenting or the carotid endarterectomy. As for the exclusion criteria, so all patients who have had previous ipsilateral interventions have been excluded. The unsuitability for the carotid stenting, either to the classifications or if there have been a high risk for the carotid endarterectomy, they have been excluded from the randomization. Okay, what's the procedure? As for the carotid stenting, any approved devices have been allowed, and the antiplatelet agents, they have been Plavix and the carotidic aspirin. So it's a dual antiplatelet. And as for the carotid endarterectomy, shunting and patching, they were optional. The long-term medical care was similar between the two groups. As for the follow-up, so patients post-operative, they have been assessed by the neurologist during their hospital stay, and the first follow-up visit was 1 month after treatment, and then they have been yearly. And the aim for this trial was to have a 5 years of follow-up, and they had that. Okay, so what's the outcome measures and the endpoint classifications? So number one, they look into the procedural mortality and morbidity. Basically, in particular, they look into the incidence of the stroke and the incidence of MI. The second, non-procedural strokes. That's for the secondary outcome measures. So they look for the non-procedural strokes. In order to do that, they use a modified ranking scale, that's a scale to evaluate the patients with these strokes. This scale classifies the patients with stroke into 3 categories. So number one, the non-disabling stroke. Number two, disabling strokes. Number three is a fatal stroke. As for the analysis, they use this descriptive analysis, basic descriptive analysis. They use intention to treat analysis. As for the procedural hazard, it was represented as a tabular method. And non-procedural hazard, non-procedural stroke, they use a Kaplan-Meier test, which is a test for survival, and the long rank method. Okay, as for the results, so between 2008 and 2020, They randomized 3,600 patients from 130 centers and 33 countries. They had, as for the carotid stenting, they had 1,800 patients, and also for the carotid endarterectomy, they had also the similar number, which is 1,800 patients. So as we can notice that for the carotid stenting, most patients, they had the surgery within 1 year, with a median days, it was 14 days, they had the surgery. A couple of patients had the surgery later. For carotid stenting, we have one patient, they have been crossed over to the carotid endarterectomy after randomizations. 100 patients, they did not have any carotid surgery. As for the carotid endarterectomy, the 1,800 patients have been randomized. Most of the patients, they had the surgery within 1 year. About 48 patients, they have been crossed over to the carotid stenting after randomizations. And 78 patients, they never had any carotid procedure. So at the end of the after randomizations, we can see that we have 1,600 patients, they had carotid stenting, and 1,788 patients, they had carotid endarterectomy. So what was the reason for crossing over from the carotid stenting to the carotid endarterectomy? So after randomizations, they discovered that the carotid artery was more tortuous or was more calcified. So then they crossed over the patient to carotid endarterectomy. As for the carotid endarterectomy, the patients, if they have been unsuitable for the general anesthesia, or they have been high risk after randomization, they will be crossed to carotid stenting. As for the baseline characteristics, demographics for the patient, so this table is just a descriptive analysis for those patients. Both groups, they have been comparable between the percentage. Male patients, they were the majority of the patients, they were almost 70%, and the female patients, they were 30%. So we have the comorbidities for the cholesterol, for the medical history. As for the carotid stenosis, for the ipsilateral carotid stenosis, among our patients, so the majority of patients, we had from 70 to 90% of carotid stenosis. A couple of patients, they had less than 70%, and a couple of patients who had more than 90%. Okay, so the first table, the first result we're gonna discuss about is the procedural mortality and morbidity. So we have death, strokes, any type of stroke. We have MI within 30 days of the carotid procedure. So we're gonna discuss by the patients who have been randomly allocated to carotid artery stenting. We're going to talk about the non-disabling stroke. So patients who have been randomly allocated to the carotid stenting, they have incidence of non-disabling stroke of 2.7, and patients who had carotid endarterectomy, they had an incidence of non-disabling stroke of 1.6 with significant changes, with significant differences. And patients who actually had the carotid stenting after randomization, they also had similar incidence of the non-disabling stroke, 2.7, and the carotid endarterectomy, 1.8. So we can notice that there's a slightly significant differences for the incidence of non-disabling stroke among patients who had carotid stenting. As for the death, disabling stroke, so it's a fatal stroke. We are talking about 1% for both groups who had this incidence. So the incidence of death on disabling stroke, 1% among both groups, which is below over there. And if you look into the any stroke for the three types, fatal, disabled, or the non-disabled, we can notice that we have 3.6% with carotid stenting, and we have 2.4 with carotid endarterectomy. So in overall, in this stroke, we have a slightly higher percentage with carotid stenting. That's for the procedural stroke. As for the MI, we have for the fatal MI, we have it with the carotid endarterectomy and 0 patients with carotid stenting. And even with the non-fatal MI, we have a couple more patients with carotid endarterectomy. So in this figure, it represents the patients, the procedural fatal events on disabling stroke. So as I mentioned before, we have 1% of fatal and disabling events, disabling stroke have been with the post-procedure 1%. So as we can also see that most the disabling or fatal events have been occurred within the first 10 days of the procedures. And after that, we can notice we have a plateau for the events. And both of them, they are 1% and the p-value was not significant. And for this figure, we can, it's represent any stroke. So the 3 types and the death. So that's the overall morbidity and mortality. So the overall morbidity and mortality in terms of stroke or death is slightly higher with patients who underwent a carotid stenting, 3.4, and it's less. It was a little bit less for patients with carotid artery with the carotid endarterectomy, with a percentage of 2.7. The p-value was 0.12. So that's not significant, and also, we have the same line of the events. Most of the events have been occurred within the first 10 days, and after that, we have our plateau for the events. Okay, so that's for the now we're gonna move to the non-procedural strokes. That's for the follow-up for the 5 years of follow-up. So for the mean duration of follow-up, which was almost 5 years. By excluding the patients who had procedural stroke and the death, for the carotid stenting, we have 1,700 patients, and also for carotid endarterectomy, we have almost 1,700 patients. So for the fatal events, for the fatal strokes, we have almost 1% for both groups. And as for the disabling events, was almost the same, 1.5 for both groups. However, for the non-disabling strokes, we also can notice that we have a slightly higher non-disabling stroke among patients who underwent carotid stenting, which with a percentage of 2.7%, and the carotid endarterectomy, they had 1.9. So there's a slightly higher percentage with the carotid stenting. And with the overall procedural stroke, we also have a higher non-procedural stroke with the carotid stenting, 5.2%. And with the carotid endarterectomy, we have 4.5%. If you look into the carotid endarterectomy, we have the incidence for the cranial nerve palsy. So we have the hypoglossal nerve, it's being the most injured, and then we have the other nerves. With the carotid stenting, they had a zero cranial nerve palsy. Okay, so that's a Kaplan-Meier figure. Kaplan-Meier is a test of survival. So they have a 5-year outcome for the patients who were randomly allocated to the both groups. So this figure, it's represent the non-procedural fatal disabling stroke. So we can notice that, so the overall fatal or the non-disabling, disabling strokes, we have 2.5 for both groups. The blue dot, that's for the stenting, and the red, that's one for the carotid endarterectomy. So both of them, at the 5 years of follow-up, they had the same percentage for the non-procedural fatal or disabling strokes, with no significant differences. And the relative risk is 0.98, and the p-value was not significant. Another figure for the Kaplan-Meier analysis, that's for the non-procedural stroke overall. So they took the 3 types of stroke for the 2 groups. So with the blue dots, that's the carotid stenting, and we can notice that by the end of the 5 years, we have more patients who had non-procedural strokes. We have with carotid stenting with a percentage of 5.2, and the carotid artery with the carotid endarterectomy, they had less than the carotid stenting with a percentage of 4.5 by the end of the 5 years. The p-value was not significant. The relative risk was 1.16. Okay, and by the end, they did a subgroup analysis for the long-term non-procedural stroke rate, but divided by the basic demographic, the basic characteristic for the patients. So they took the age, the gender, the type of the ipsilateral carotid, the degree of the stenosis. They took all that and they made the comparison by the non-procedural stroke. So by all these factors, they did not find any significant relation between the incidence of the stroke and these basic demographic variables, and yielded no evidence for the type of the effect for the treatment. As for the discussion, so our neighbors, the German, they had the German study, which have been conducted from 2014 and 2019. They took the whole patients who underwent carotid endarterectomy and carotid stenting, and the incidence for the disabling stroke or death in hospital stay was 0.7%, and the mean time for the in-hospital stay was 4 to 5. And they calculated that. They said if they had the 0.7 incidence of the disabling stroke or death within the hospital stay, then by the end of the month, they would have a 1% of the incidence of the disabling stroke or death. And that's exactly what our trial have came up with, exactly the same percentage. However, also in the German registry, they had slightly more incidence of the non-disabling strokes with the carotid stenting. At the end, I have a couple of tables that's from the study protocol. So the carotid stenting has been done by the radiologists, by surgeons, by others. Some of them, they were neurological interventionists. So they did not find any, so this table represents death, any stroke or MI following the carotid stenting, classified by the surgeons or by the radiologists. There are not much differences between the radiologists or surgeons doing the carotid stenting. I can notice that maybe we are the surgeons, we have 4.7 and the radiologists 3.4. Maybe we are more strong than them. And we have a little bit higher percentage. However, that's not significant. As for the carotid stent has been used with carotid stenting, the colossal wall stent, it's been the majority, almost 50%. And we have the other types for the stent. So they use the protage, they use the X-link. That's suitable for the type of the stent. As for the filters, so a couple of hospitals, they use the filters. Some of them, they use the proximal occlusion devices, and some of them, they use a distal balloon. However, the majority of the centers, they used filters, and being the filter wire is the mostly widely used. Some centers, they did not use any cerebral protection devices. For carotid endarterectomy, as I mentioned before, the patch or shunting, it was optional. So by the end of the study, the patch had been used for 700 patients, 900 patients who did not have any patch. Shunting, most of the patients, they did not require a shunting. And the anesthetic type, the patients have been on general anesthesia and patients have been on the block local regional. As for the collaborating clinician, most of the patients came from Italy. The other patient, they came up from the UK, and I mentioned here 47 patients who came from France. And in Paris, we have the Mondoc Hospital. Move up. So I'm going to conclude the presentations so the main presentation from our trial is that the two procedures have the same impact on the disabling or fatal events, about 1%. And for the procedure hazard of the 5 years, however, for the non-disabling strokes, the carotid artery stenting, they have a slightly higher percentage with the non-disabling stroke.
Thank you, Mohamed.
Thank you.
In fact, we used to say for CAS, we have higher risk of stroke and less risk of MI, and the contrary for open surgery. In this case, when we see the curves about the perioperative curves, it seems that we have a trend to have a higher risk of stroke in the CAS group, any cause, any type, I mean, of stroke in the CAS group. But I don't see any difference between both groups for perioperative MI. It's correct?
That's correct. MI is...
Ça aurait été intéressant d'avoir l'analyse tout petit sous-groupe des pourcentages de morbidité neurologique et générale en fonction de l'utilisation des filtres. Pas de filtres.
Parce qu'il y a beaucoup de filtres utilisés. Hein.
Ouais, il y a
presque 60%.
Le système de protection ou pas? Est-ce que finalement.
Oui, le système de protection.
Malheureusement, elles sont réalisées.
Ouais,
parce qu'entre les, tu peux peut-être revenir dessus, mais entre les filtres et les systèmes d'occlusion, c'est presque 80% des patients, je crois. Filtre 70% et oxymalocclusion, oui, c'est 84% des patients ont eu un système de protection cérébrale. 85% si on prend des stades ballonnaires. Ce qui est très très important.
Oui, c'est ça. Et est-ce que c'est protectif ou pas? On a l'impression qu'il y a vraiment une tendance à protéger le carotide distal, mais est-ce que réellement il y a un intérêt ou pas? Alors, autant je trouve qu'il y a une vraie hétérogénéité potentielle dans le groupe CAS, autant je trouve que quelle que soit la méthode utilisée pour l'endartériectomie, finalement, on est à peu près la même chose. Il n'y a pas la différence, elle se fait sur le long terme, pas sur le court terme. Et on ne semble pas y avoir quelque chose de bon.
Alors, par contre, il semble que, alors ça, je n'ai pas très bien compris, mais à moyen terme, dans le suivi, il semble qu'il y a un taux d'AVC plus important dans le groupe CAS, où en tout cas, il y a une tendance, après, peut-être qu'il faut revenir en arrière sur les courbes. C'est ça, ouais.
Ça,
après. Mais bon, c'est pas significatif, ça.
Ça, c'est pas significatif. Ça pour the whole type of strokes. Les trois types de strokes. 97 strokes.
Après, l'échelle est toute petite, hein, c'est l'échelle sur 100%, et là, c'est un zoom vraiment sur entre 0 et 4. Hein, donc, c'est la différence qui apparaît quand même. On voit sur la courbe, en fait. Si on regarde les chiffres, hein, c'est P égale 0,33, donc c'est vraiment pas différent.
C'est exactement, c'est ça. 91%, 91 patients en CAS, 79 peut-être.
Je trouve que ce qui est mal évalué également dans la chirurgie ouverte, c'est l'impact des nerfs crâniens. Parce qu'on sait, ça en pratique quand même si effectivement ça ne tue pas, ça peut être extrêmement handicapant pour un patient. Le nerf crânien, le boost par exemple, ça peut vraiment impacter la vie du patient et à long terme. Ça, c'est vrai que ça n'apparaît pas dans c'est évalué, mais mon critère principal, c'est pas pris en compte. J'ai pas l'impression.
Non, c'est pas la principale. Du coup, c'est pour le stenting, il y a le transfémoral, le carotide, ils sont bien dit, ils sont utilisés le fait de la technique. Il y a le fémoral.
On ne sait pas.
On ne sait pas ici.
C'est un point aussi important.
C'est très important parce que si on fait transfémoral, higher incidence.
On dit qu'il y a 1% d'AVC, rien qu'avec le catétérisme de la crosse. Je crois que c'était les chiffres un petit peu, dans les archéographies de la crosse, il y a à peu près 1% d'accidents. Donc, effectivement, ça n'a pas de. Alors, il y a un autre point également, c'est une super vécu. Ce qu'on peut remarquer, c'est quand même la longueur de l'inclusion. Il y a eu 300 patients inclus, mais les inclusions publiées bien au départ, c'est entre 2008 et 2020. 12 ans pour inclure, il y a 5600 patients. Non, 3600 patients. Mais 12 ans pour inclure tout ça. Alors, c'est une chirurgie où c'est connu, dans tous les pays. Plusieurs dizaines de milliers de patients. Si, toujours. Hein. On bien en France particulièrement. Très bien. Eh bien, merci Mohamed pour cette présentation.
Merci beaucoup. Merci.
Allez, à la semaine prochaine.
Merci.